Hello everyone, I'm Dr. Jiji George, Department of Oral Pathology, BBD College of Dental Sciences, Lucknow. I'm here today to speak about chondrosarcoma. So in today's lecture, we'll deal in detail about chondrosarcoma. So chondrosarcoma is a malignant tumor of the connective tissue origin. Now, cartilage, before learning about chondrosarcoma, it would be better that if we understand about normal cartilage. Now, cartilage, usually we hear about the hyaline cartilage, and the hyaline cartilage has got the cells which are entrapped within its own matrix called as chondrocytes, and they are the mature cartilaginous cells. And the cells which basically secrete cartilage is called as the chondroblasts. So the difference between blasts and cytes are the same as in the usual cell types. The chondroblasts are the active cells which secrete cartilage, and chondrocytes are the mature cartilaginous secreting cells which have already finished their function and are entrapped in their own matrix. So the chondrocytes, like the osteocyte, is always entrapped in a lacuna inside its matrix. The difference would be that a chondrocyte would be in a lacuna, not alone, but in groups. That is, it can be either in groups of two or it can be in groups of four. So it's always seen in pairs. So when you see the matrix of the cartilage, you can actually notice that there's a basophilic staining characteristic. So that's about a normal cartilage. Now coming on to chondrosarcoma. So as I said, it is the malignant tumor characterized by cartilage formation. So like any other malignancy, this tumor will also have certain features which are normally seen in any malignancy. So you will have features of atypia in these cells. So that is the cellular features of malignancy. On a cellular basis, any malignancy will show cellular features of atypia. So that is what you will be seeing on a cellular basis. Now this rarely involves the jaws. So as far as a dentist is concerned, you might not always see a chondrosarcoma. But having said that, it is not impossible to come across a patient of chondrosarcoma. So this has a better prognosis than osteosarcoma. Osteosarcoma, as you all know, is a bone tumor, malignant bone tumor, which is more fatal and risky than a chondrosarcoma. It has poorer prognosis. So the chondrosarcoma can be a primary lesion which develops de novo. De novo means it develops by itself. It's a primary lesion. It's a first lesion that develops. It does not develop from a different lesion. Now, secondary chondrosarcoma is one which has a pre-existing precursor. That is, it can develop from an already existing chondroma. Now, chondroma is a benign counterpart of this chondrosarcoma, which means that the benign tumor of cartilage is called as chondroma, and the malignant counterpart of chondroma is called as chondrosarcoma. So, because it is a sarcoma, we all know that all sarcomas will spread through the hematogenous route, that is through the blood vessels, unlike the carcinomas which spread through the lymphatic route. So anatomically, we have different types of chondrosarcomas. The first type is intramedullary. When I say anatomically, I mean to say that according to where the site of origin of the chondrosarcoma or where is it seen. Intramedullary, that means inside the medulla, that is a central type. Central type is inside the bone. Whenever you hear the word central in case of these lesions, you know that it is intraosseous. So intramedullary can be there. Then you can have a peripheral type. Peripheral means it is seen in soft tissues, arising in the soft tissues. Then you have juxtacortical. Juxta means just outside. Just outside the cortex is the periosteum. So you can see it on the periosteum. So it's called as juxtacortical or periosteal, and or primary or secondary. So primary arises de novo by itself. It does not have a precursor. Secondary has a precursor, which can be a benign tumor like a chondroma. Now that was about the anatomical types. Now coming on to the typical types of chondrosarcoma, which is histological. One is conventional, which is usually found, and the other one is dedifferentiated. Then it's mesenchymal and clear cell. Now, clear cell just shows the type of cell which is seen in the chondrosarcoma. Now, having said that, no sarcoma or no tumor might show a normal looking cell of origin. There are chances that these tumors can show a lot of variations. So clear cell chondrosarcoma is a type of chondrosarcoma where you have chondroblasts and chondrocytes, but then these tumor cells have undergone a clear cell change. So that is called as a clear cell type of chondrosarcoma. Dedifferentiated and mesenchymal chondrosarcomas are both a little biphasic in nature histologically. So I'll come to that in detail in the coming slides. So coming on to the clinical features, it does not have any pathognomonic signs or symptoms. When I say pathognomonic, I just mean to say that no characteristic signs or symptoms are there, and it has got a usual male to female ratio, which is 2:1. Now, types I've already discussed, and in the jaw, like we are more interested in knowing about the jaw lesions of chondrosarcoma, that is which affects the maxilla and the mandible. So they're expansive and painless. So when I say expansive, I just mean that the buccal and the lingual cortical plates can expand, but it is painless in nature. So it will only cause pain if it kind of intrudes into some nerve in the maxilla or the mandible. Otherwise, it has an intact mucosa. It has an intact mucosa clinically because it's all the growth is taking place inside the bone or in the soft tissues. It's not coming out of the epithelium. So you will have an intact epithelium until and unless the tumor will perforate the epithelium. So the most common site is the maxilla, because maxilla is a bone which arises from a lot of these cartilages. And you can see resorption and exfoliation of teeth. But obviously, because if a part of maxilla is affected, it will obviously show resorption and exfoliation of the tooth, because the sockets will be affected. So it can metastasize, so which means that any malignant tumor obviously can spread to a distant site. So that's what is called as metastasis. And I already mentioned metastasis will happen by the hematogenous route. Now, the maxillary tumors can cause nasal obstruction or congestion, epistaxis or photophobia. Now, that's common with any obstruction which takes place inside the nose or the maxilla. That is the maxilla, the body of the maxilla or the maxillary sinus or the nose, all of them are in very close approximation with each other. So obviously a tumor of the maxilla can intrude into the nose and cause nasal obstruction or nasal congestion. It can even intrude into it can cause bleeding inside the nose. That's called as epistaxis or photophobia, because just above the maxilla you have the floor of the orbit. So if it perforates into it being a malignant tumor can perforate into the orbital space and cause photophobia by compressing the optic nerve. So the radiographic features, obviously chondrosarcoma will have radiographic features, because you will find bone destruction in long-standing lesions. So the surrounding bone will be destructed. So whenever there is a destruction of bone due to a malignant tumor, we will find radiolucency. Now, you can also find calcification of neoplastic cartilage. That is, the chondrosarcoma is basically a malignant cartilaginous tumor. So obviously you can expect to find neoplastic cartilage. So this neoplastic cartilage can sometimes undergo calcification, because our body will always try to mimic a normal process. So there is something called as an endochondral bone formation, where cartilage is initially formed and then that will calcify to form bone. So our body will always try to attempt a normal process. So here the neoplastic cartilage will attempt to form calcification, and that will show a radio opacity on the radiograph. Now, sometimes there can be a penetration or perforation of the cortex, and it might cause a sunburst pattern. Now, sunburst pattern is actually a very characteristic radiographic feature of malignant bone tumor, that is your osteosarcoma. But having said that, it can be seen in chondrosarcoma as well. Now, there can be an extensive infiltration between osseous trabeculae of the pre-existing bone without appreciable resorption. So if there is no resorption, then obviously there'll be no displacement of tooth, much displacement of tooth, and there's no pain. So until and unless the patient does not have pain, he's not going to come to the dentist. So also you can see in the radiograph, you can see a symmetric widening of the periodontal ligament space, which again is very characteristically seen with osteosarcoma. So if you find a very symmetric generalized widening of the periodontal ligament space, you should think in terms of either a chondrosarcoma or a osteosarcoma. Now, this can also call root resorption in later cases, but not always seen. Now, histopathology, to understand histopathology, you have to go back to what is the normal cartilage structure. So as I already told you that the normal cartilage structure consists of chondroblasts as well as chondrocytes. The chondroblasts are the immature, the bone cells which are, the cartilage forming cells which are going to form cartilage actively. And the chondrocytes are those mature cartilage cells which have already finished their function of forming cartilage, and now they're present in pairs of 2 or 4 inside a lacunae. So this is a normal cartilage structure. So now we will discuss about what happens in histopathology of a chondrosarcoma. So whenever we talk about a malignant tumor, we always have to understand that there will be cellular changes on a cellular level. So the changes on the cellular level has to be explained by explaining how the structure of the cell is going to be. Now, a conventional chondrosarcoma will reveal a mixed lytic and a sclerotic pattern with small calcifications. Now, since we are talking about uh, the histopathology, these small calcified areas will be seen as popcorn or ringlet calcifications, because we have to imagine the shape of a popcorn or a ringlet in case of these calcifications around the cell in case of the chondrosarcoma. Now, hyaline cartilage can be seen showing varying degrees of maturation and cellularity. Now, that is very important because, as I said, that whichever tissue, our body will always try to resemble or try to attempt to look like a normal tissue. So, it will always attempt normalcy. So, the initial phases where your differentiation of the tumor is very good, where it will resemble the parent cell, you will find more normal looking hyaline cartilage and a few cells which are atypical. But later on, in gradually, when you if you see a high grade tumor, you will actually see that the hyaline cartilage does not resemble the parent cell at all, and you can hardly figure out if it is a cartilage or what kind of a mesenchymal tissue it is. So that's why I meant to say that you will find hyaline cartilage, but depending upon the stage of the tumor, it will be in varied degrees of maturation and cellularity. Now, there'll be typical lacunar formation within the chondroid matrix, that is, if the tumor is well differentiated. So, a well differentiated tumor, as I said, would resemble the cell of origin. So, if it resembles the cell of origin, you will definitely find a typical lacunae, like I always already said, that a normal cartilage is going to be, and with a chondroid matrix around it. That means the normal cartilage or the cartilage forming cell or the chondroblast will actually get entrapped in its own matrix and form a chondrocyte. And here, if at all, it is a well differentiated lesion, that is, if it is the earlier stages of a lesion, you will find similar picture where there'll be typical lacunae formation with chondroid matrix. Now, when the tumor starts to grow, obviously it's a malignant tumor, so it has to grow. The growth component will be really high. So it will show a lobular growth pattern. Whenever I say that there is a lobular pattern, I mean to say that in between lobules, there are connective tissue septa. So the lobules represent these tumor cells, and in between these tumor lobules, you will find a connective tissue septa. That will be just a collagen fiber septa, which you can see surrounding it. Now, the central area of lobules will show maturation. That is, you will find mature calcified cells inside the central area of these lobules, and the peripheral area will contain immature cells or spindle cells, immature cells will hardly resemble the parent cell, and the mature areas will actually resemble the parent cell. So what I mean to say is, when you see a mature area, you will recognize that it's a cartilage. So you can think in terms of a tumor arising from a cartilage. You will know the origin of the tumor. But if you just see the peripheral areas which are immature, you might not say that with ease that this tumor might arise from a cartilage. So that is how you have to understand the histopathology. So depending upon all these factors, we can grade the chondrosarcoma into three grades: grade 1, grade 2, and grade 3. So grade 1 would be well differentiated. I mean to say that they will resemble the parent cell to a greatest extent, and grade 3 will resemble the parent cell to the least extent. So when you look at grade 1, you will find more or less normal looking cartilaginous tissue, and in grade 3 you will find more or less abnormal looking cartilaginous tissue. So the points will be the same. So we'll just discuss grade 1 and grade 3 because grade 2 is in between. So grade 1 basically mimics a chondroma. Chondroma is a benign tumor of the cartilage. So I mean to say that it will look like a normal cartilaginous cell, but increased in number, increased proliferation mechanism. But at the same time, in grade 3, there'll be a gradual increase and it will be highly cellular. So which means that the normal number of cartilaginous cartilage producing cells or the chondroblasts will be very high in grade 3. So whichever malignant tumor, when you have to talk about grades of a malignancy, obviously you have to look at the cellularity. Whenever there is increased cellularity, that means the grade of the tumor is increasing from good to bad. Now, in grade 1, you will only find subtle variation from normal cartilage. That is what I said, it will resemble the parent tissue. Whereas in grade 3, it will not resemble the parent cartilage tissue, which makes it very difficult for you to understand whether the tumor is a cartilaginous tumor or otherwise. So in grade 1, it is considered malignant only if large chondroblasts and binucleated chondrocytes are present. But that means you can still recognize that it is a cartilaginous tissue that you're dealing with. Whereas in grade 3, it is easily recognizable that the cartilage area is very scarce. That means you will not be able to find much of very familiar looking cartilage tissue. So there'll be rare mitosis, obviously will be more in a high grade lesion because the proliferation of these lesions will be more. So you will find that that is when we use the word poorly differentiated, because it does not resemble the parent tissue at all. So the lacunar pattern, again, I told you that normally you will find cartilage inside the normal chondrocytes inside a lacunae arranged in pairs. So this lacunar pattern will be absent in a high grade lesion because they no longer resemble the parent cell. So that's about the 3 grades of chondrosarcoma. Now, this is one point which is worth a mention because it's very important for a pathologist to know the difference. So sometimes I said that you can find popcorn or ringlet kind of calcifications, but sometimes you can actually find neoplastic osteoid. So if at all you find neoplastic osteoid, how will you understand if the osteoid that is formed is neoplastic or reactive? You will find atypical cells inside the cells with a lot of atypical features inside the bone. Then that is called as neoplastic osteoid. A reactive osteoid will not you will not show any atypia. So if at all you find neoplastic osteoid in a lesion, that lesion should be considered as an osteosarcoma with chondroblastic differentiation. So if I have to explain more on that, I would rather rephrase it like this. I'll say that I'm able to see a lot of chondroblasts and a lot of cartilage, but then at one point I can see osteoid which is neoplastic. So if I find neoplastic osteoid, I have to characterize it as an osteosarcoma. And then to subdivide that type of osteosarcoma, I would rather give my diagnosis as osteosarcoma with chondroblastic differentiation. So I just mean to say that the importance has to be given to the neoplastic osteoid if seen in a chondrosarcoma. So that's a very important point. And in this picture, you can actually see the different phases of the zones of a cartilage or the differentiation of cartilages. Here you can see resting chondrocytes. These are arranged inside a lacuna, and here you can very clearly see that there is an increase in number of these chondrocytes, and you can see that the nuclei are also more basophilic in nature, which means that there is more of proliferation happening here. And there's a slow transition zone where you can see the size of these chondrocytes increasing in size, and then there is a lot of hypertrophy. So that these are the zones of a chondrosarcoma. And the last phase is ossification phase, where you will find some calcification taking place. Now, having said that, I've already discussed that we have different types of histological types of chondrosarcoma. So the first is mesenchymal chondrosarcoma. From the name, you know that these chondroblasts and the chondrocytes, they're basically mesenchymal in origin. So you will obviously find small ovoid undifferentiated cells. Now, when I say undifferentiated, I mean to say that they don't resemble their cartilage precursors at all. So they're interspersed by islands of well-differentiated cartilage. So basically, you're able to see a two biphasic pattern. That is, in one area, you will find undifferentiated cartilaginous cells, which basically you can't make out that is a cartilage. You think that it is a totipotent mesenchymal cell. And very adjacent to that, you will find well-differentiated cartilage. So when you see the well-differentiated cartilage, now you can obviously assume that the mesenchymal cells which are seen next to it are actually undifferentiated cartilaginous cells. That's why we use the word bimorphic. So a bimorphic pattern will show a poorly differentiated mesenchymal cells. That's what I said, undifferentiated mesenchymal cells. And adjacent to that, you will find a very well-differentiated cartilage, which is already formed over there. So that is why it's called as a bimorphic pattern. So the amount of cartilage will vary, and the transition from the cellular area, that is your undifferentiated mesenchymal cell area, with the cartilage is usually very abrupt. So the next is the clear cell type, which I've already discussed, that the cartilaginous cells, the cartilage forming cells, will show a very clear cell cytoplasm. I mean to say, it look empty in a H&E stain. So it look like a clear cell. There's a cleared out area of the cytoplasm. The next type is the dedifferentiated type. So dedifferentiated is a very high grade malignancy. So when I mean what I mean by the word dedifferentiated is, differentiation is going one step ahead towards, being functionally more mature or a terminal maturation of cells. And dedifferentiation means going back, reverting back to something primitive is called as dedifferentiation. So here you will find a mixture of well-differentiated chondrosarcoma along with a malignant mesenchymal tumor resembling a fibrosarcoma. So please differentiate between the mesenchymal type and the dedifferentiated type. In mesenchymal type, you found undifferentiated mesenchymal cells and adjacent to a well-differentiated chondrosarcoma. But in this case, you will find a well-differentiated chondrosarcoma along with another tumor, which looks like a fibrosarcoma. That means you will find spindle-shaped fibroblast-like cells, which also show a lot of these atypical features. So this is a histological picture which clearly shows the blue colored matrix of the chondrosarcoma, as I already told you. And you can see that there are a lot of these. It's a highly cellular lesion, but then you can find out that these chondrocytes are, these cartilage forming cells are very closely arranged to each other. So that this is a typical picture of a chondrosarcoma. Now this picture is shown just to show you the difference between a benign chondroma from a malignant chondrosarcoma. So this, the picture up shows a benign chondroma where you can actually see the chondrocytes in the lacunae and they are spaced out. And they are small in size and they're regularly shaped. But at the same time, in this chondrosarcoma, the picture below, you can actually find that the size of the chondrocytes have actually increased in size. And you can see that they are in an enlarged lacunae showing a lot of these nuclear hyperchromatism. And the cells are showing a lot of pleomorphic appearance. So this is a very telling feature of the difference between a chondroma and a chondrosarcoma. So this again shows how the chondroma, this blue area is entirely the chondrosarcoma area. So you can see how the cartilage tumor is kind of jutting inside a bony tissue. This is normal bone. So since you can't see any dysplastic cells in this area, this is normal bone, and you can see how cartilaginous tumor is getting inside. Now this is a picture where this area that I'm showing is the root of the tooth, that's the cementum, and this is the periodontal ligament. This is your periodontal ligament, the soft tissue, and obviously the adjacent area has to be the alveolar bone. But then in the alveolar bone, you can see cartilaginous differentiation, which means that there is a chondrosarcoma in this case arising inside the socket of the given tooth. So this is again a mesenchymal chondrosarcoma showing round and oval cells and small amounts of cartilage. You can see that small cartilaginous elements are there. Over here you can see small cartilaginous elements, but then it is more or less very cellular in nature. So that's a mesenchymal chondrosarcoma. So that is where we end today's class. Thank you for the patient listening. Next class we will deal about osteosarcoma, which is the bone tumor. Thank you very much.